Okay, fine. Okay, right. Okay. So today we will be dealing with the new topic, that is the blood. Okay. In blood, first we will start with the erythropoiesis, and later on we will move on with the as and when the topics come. Okay. So today we will mainly focus on the RBCs and the WBCs. So we will first start with the RBCs, that is the erythropoiesis. Okay. So it's also called as hemopoiesis altogether. Okay. Hemopoiesis. So it is a production of the blood cells. Either it may be the RBCs, WBCs, or the platelets. So it is hemopoiesis. So the hematopoietic tissues. What are the hematopoietic tissues? Okay. So they are nothing but the blood forming tissues producing the RBCs, WBCs, and the platelets. Okay. So there are two types of hematopoietic tissues. One is called as the myeloid tissue, and other is called as the lymphoid tissue. Okay. Myeloid tissue and lymphoid tissue. Okay. What is myeloid tissue? So myeloid tissue means it is the red bone marrow. Okay. Myeloid tissue means it is the red bone marrow. Okay. It produces mainly the cells belonging to the myeloid series. Okay. Cells belonging to the myeloid series are produced by the myeloid tissue. So the myeloid series means it is the RBCs, that is the red blood cells. Then the granulocytes, mainly the neutrophils, eosinophils, and the basophils, and monocytes. Okay, monocytes. Also platelets. So all these cells belong to the myeloid series. Okay, it also produces the precursors of lymphocytes. Okay, so this myeloid tissue also produces the precursors of the lymphocytes. Okay, so what is the ratio? Okay, what is the ratio of the myeloid to erythroid ratio in the marrow? Okay, normally 75% of the cells in the bone marrow belong to the WBCs. Okay, so they mainly produce 75%, that is the which belongs to the WBCs. Okay, of the myeloid precursors or the series. Okay, and rest 25% belongs to the erythroid series, which ultimately produces the RBCs. So if you take the ratio, okay, myeloid to erythroid ratio, that is 3:1. Okay, WBC is 75% and erythroid 25%. So 3:1. So this question has been asked n number of times. Okay, just remember in the bone marrow. Okay, read the question very properly. Okay, don't be in a hurry. So in the bone marrow, the myeloid to erythroid ratio is 3:1. Okay, only in the bone marrow. So when it comes to the circulation in the peripheral blood, it is different. Okay, but in circulation, what happens? There are 500 times as many as RBCs when compared to the WBCs. This is because of the short lifespan of WBCs, because the WBCs have got very short lifetime. In circulation, you can see 500 times more the number of RBCs, because RBCs have got a longer half-life, that is 120 days. Okay, 120 days is their lifespan. So therefore, read the question properly. In the circulation, it is the RBCs which are dominant, but in the bone marrow, it is the WBCs which are the dominant in 75%. So myeloid to erythroid ratio in bone marrow is 3:1, but in circulation, you will find that there are 500 times more RBCs when compared to the WBCs. Next, coming to the lymphoid tissue. So lymphoid tissue includes lymph nodes, thymus, and the spleen. Okay, so this mainly produces the lymphocytes, that is lymphoid series or the lymphoid tissue. Okay, next, coming to the erythropoiesis proper. Now we will mainly focus on the erythropoiesis. So what is erythropoiesis? Erythropoiesis is defined as the process of formation of red blood cells. Okay, it is the process of formation of the red blood cells, which starts as early as the third week of intrauterine life. Okay, it starts at the as early as third week of the intrauterine life. So this third week, so it is asked a number of times again. Okay, just mark it. Okay, third week is the, it starts as early as the third week of the intrauterine life. So okay, it continues as long as the person is alive. It continues as long as the person is alive. Okay, So coming to the sites of erythropoiesis. Next comes the sites of the erythropoiesis. So in the intrauterine life, we call it as intravascular. So sometimes this question can be tricky and asked. So where is the intravascular site for the production of the RBCs? So it is the intrauterine life. So that is the mesoderm of the yolk sac. Okay, that we call it as mesoblastic phase. So during the intrauterine life, what happens? Erythropoiesis first takes place in the mesoderm of the yolk sac. Okay, the mesoderm of the body. So this is called as mesoblastic stage. So during this stage, erythropoiesis is mainly the intravascular. Next comes the hepatic stage. That is from 5th week of gestation, the erythropoiesis is taken over by the liver and the spleen. Liver and the spleen. Okay. Next, what happens later from the 5th month of intrauterine life, the bone marrow starts producing the red blood cells. That is the medullary stage. So that is the myeloid phase or the medullary phase. However, the erythropoiesis in the bone marrow is very slow in the second trimester. Okay, very slow in the second trimester. So after the birth, it is mainly the red bone marrow, which is mainly the site for the production of the RBCs. Okay. So intrauterine life and after birth. So in the intrauterine life, it is intravascular, mainly the mesoblastic stage, hepatic stage, and the medullary or the myeloid phase. So in the intrauterine, as I told, it starts as early as the 3rd week of the intrauterine life, and up to it goes up to the 3rd month of the intrauterine. That is the mesoblastic stage. Okay. Okay. It starts in the 3rd week of intrauterine life. So here it is the mesoderm of the yolk sac. Okay, so it is called as mesoblastic stage. Okay, so it's also known as intravascular erythropoiesis. Intravascular erythropoiesis. Okay. Next, from 3rd month to 5th month, as I told, it mainly occurs in the hepatic stage. That is the liver and spleen, which and sometimes the lymph nodes as well. Okay, so here it is called as the hepatic stage. So we call it as hepatic phase. Okay. So from 5th month onwards, it is the bone marrow. Okay, that bone marrow. So we call it as medullary stage. Okay, okay, myeloid stage or the medullary stage from 5th month onwards. So it is called as myeloid or the medullary phase. Okay, so postnatal life. So after the birth, what happens? It is only in the red bone marrow where the erythropoiesis occurs. Okay, erythropoiesis occurs after the birth. It is mainly the RBM, that is the red bone marrow. So in younger children less than 5 years of age, bone marrow is the essential of all the bones. So bone marrow of all the bones produce RBCs. Whatever the bone may be, the bone marrow produces the RBCs. What happened? Hello? So as the age advances, some of the bone marrow is replaced by yellow fatty filtration. So that is the yellow bone marrow. Okay, due to the fatty infiltration.
उधर भी अकेला नहीं आया था क्यों?
जैसे कि मेरे तो रहेंगे
ट्रेड कर रहे थे आए थे ना आना
हेलो
बहुत अच्छी रही
पागल पूछता हूँ लोग कौन कौन गए 3 लोग कौन है
वो उसका बाप बाकी 2 रिलेटिव्स
कौन वो
हेलो
मेरा नहीं हो कौन हो अल्लाह कौन है
चल चल
तो होसंगड़ी who is होसंगड़ी
शिवा
guys I am audible so coming to the as I told in the postnatal life in the early before 5 years of age all the bones invariably produce the RBCs and later what it is infiltrated by the yellow fatty filtration. Okay, so after 20 years the red bone marrow is mainly found in the flat bones, that is the cranial bones, ribs, sternum, vertebrae and pelvic bones and the pelvic bones. As you can see in this diagram, you can see in the later stage of the life it is mainly the flat bones. Okay, flat bones, also the upper ends of the long bones, that is the humerus and the femur. Okay, humerus and the femur. So only these are the sites after 20 years of age where you can see the erythropoiesis occurring. Okay. Coming to the one more concept, that is the extramedullary erythropoiesis. So what do you mean by extramedullary erythropoiesis? So whenever there is necessity, so whenever we require increased erythropoiesis response, okay, bone marrow is not able to meet the need, then what happens is yellow bone marrow is converted into red bone marrow. Okay, it is converted into red bone marrow. If the necessity is still not met, okay, even there can be erythropoiesis which can occur in liver and the spleen. So this is called as extramedullary erythropoiesis. Okay, extramedullary erythropoiesis. And one thing that you should always remember, that if there is extramedullary erythropoiesis, then it reflects that it is some abnormal thing is there. That is, some disease might be suspected. Okay, some disease might be suspected. Okay. So hemopoiesis in liver and spleen are physiological during the intrauterine life. But however, the hemopoiesis in these organs after the birth, okay, is considered abnormal. It is considered abnormal. Okay. Next, coming to the stages of erythropoiesis. Okay, stages of erythropoiesis. Now you have seen the sites. Now we will come to the stages. So very important. So the pluripotent hematopoietic stem cells which are present in the bone marrow, okay, they get committed to the lymphoid or the myeloid series. They either get committed to the lymphoid or the myeloid series. Okay, and from the lymphoid you can see the production of the T lymphocytes and B lymphocytes, and from the myeloid series they get committed to the granulocytes and the monocytes. Okay, granulocytes and the monocytes. Also, this myeloid series also gives rise to the erythroid series, that is the formation of the erythrocytes. So in this diagram you can see how the pluripotent stem cells, they get committed either to the myeloid or the lymphoid series, and then they differentiate to form the respective cells. And today we will mainly see the production of the erythrocytes in this series. Okay. Also, the myeloid series also get committed to the formation of the platelets, megakaryocytes. Okay. Coming to the things, okay, they are the primitive cells which are present in the bone marrow. Okay, they are called as pluripotent hematopoietic stem cells. Okay, they are pluripotent, can get committed to any of the lines, okay, series of cells. Okay, they have got two main properties. Okay, they have got two main properties, that is the self renewal, okay, and differentiation. So two properties of the pluripotent hematopoietic stem cells, okay, that is the renewal and the differentiation. Okay, so what are those properties? As I told, self renewal, so the ability to give rise to the new stem cells by cell division. Okay, whenever these cells reproduce, a small portion of them will remain exactly like the original copy, that is the pluripotent cells, and they get retained in the bone marrow as a memory. Okay, so this is called as self renewal. Okay, this property is important because it prevents the marrow from running out of the stem cells. So at any given point of time, you have got some stem cells which are always preserved. Okay, second property is the differentiation. Okay, so what is differentiation? Ability to differentiate into many different blood cells, as I told in the previous slide. Okay, so those are the two properties. As I told, this is the same diagram. Okay, they get committed to the differentiate to the various cell lines. Okay, next, when they get committed, okay, we call it as committed stem cells. Okay, when the pluripotent hematopoietic stem cells, they get committed to a certain line, then we call it as committed stem cells. So every daughter cell formed from the pluripotent hematopoietic stem cells cannot produce all type of cells. Remember, they cannot produce all type of cells. So they become committed to a particular cell line and are referred to as committed stem cells. They become committed only to a particular cell line. Okay, like myeloid series, which can produce only RBCs, granulocytes, monocytes, and platelets, as I told in the previous slide. Okay, or they get committed to the lymphoid series, okay, which produce mainly the B lymphocytes and the T lymphocytes. Next, these committed cells will become progenitor cells. Okay, as commitment progresses, the capacity of these stem cells for self renewal diminishes. Remember, as the cell line progresses to a certain commitment, okay, to a certain cell line, okay, the capacity of the stem cell becomes low, okay, for self renewal, okay. When it markedly decreases or lost, it is termed as progenitor cell, okay. They are more in numbers than the stem cells, remember. So this is a potential question, okay, MCQ. So for progenitor cell which has markedly lost its self renewal, so they are more in number when compared to the stem cells. When compared to the stem cells, there are separate pools of progenitor cells for different blood cells like RBCs, okay, neutrophils, like that, lymphocytes, okay. So these are more in number than the stem cells. So this is the same diagram again depicting. So now next what happens, the progenitor cell, they become progenitor cell in the erythroids. Now we are speaking about erythropoiesis. So the progenitor cells in the erythroid series, they get differentiated by their size of the colonies. So two colonies are there, the burst forming unit erythrocyte BFUE, and other is the colony forming unit erythrocyte, that is CFUE, okay. So these are the erythroid series of cells, okay. Guys, are you able to hear me? Are you following the class? Okay. Next, so these are the electronic picture, okay, of the burst forming unit erythrocyte colony and the colony forming unit erythroid colony. So next, coming to the further stages. So the first we will see, that is the pro-normoblast. So, okay, pro-normoblast. Second will be the early normoblast. Next comes the intermediate normoblast, late normoblast, reticulocyte, and finally it is the erythrocyte. Okay, these are the various stages. Okay, these are the various stages. So we will see one by one. Okay, we will see all these one by one. Okay, coming to the, so these are the microscopic pictures of various cells. So we'll see again in detail now, okay, in the coming slides. So it is the pro-normoblast. Okay, you can see the cell has increased. The size of the cell is very big. Okay. Next is the basophilic normoblast. Okay. Next is the polychromatic. Guys, are you able to hear me? Are you able to hear me, guys? Please reply. Smriti, are you able to hear me?
Yes, sir.
Yeah, fine. Okay. Because I'm getting, there is no audio heard. So next is the polychromatic normoblast, then orthochromatic normoblast, then reticulocyte, and finally it is the erythrocyte. Finally it is the erythrocyte. Now coming to each cell, okay, pro-normoblast. Okay, so it is the first morphologically recognizable cell. So this is one of the question asked, which is the first recognizable morphologically. Okay, that is the pro-normoblast. Develops from the progenitor cell, that is colony forming unit erythrode series. Okay, so the size is 15 to 20 micrometers. Okay, 15 to 20 micrometers. It has got a nucleus. Okay, it has got a nucleus that is large and it is in the central, almost fills the entire cell, and it is basophilic. Okay, it is basophilic, contains small blue nucleoli. So this is very largest cell. Cytoplasm is less in amount here, only about 20% of the cell, but the presence of high concentration of polyribosomes here makes the cytoplasm intensely basophilic. Okay, because of the high concentration of the polyribosomes. Okay, the cytoplasm has high content of RNA, which indicates that is vigorous protein synthesis in the cell. The nucleus is large and occupies 80% of the cell, and it contains multiple nucleoli. Okay, because of the reticulum present. So fine punctate chromatin. Cytoplasm, as told, is basophilic due to the presence of RNA. Okay, and here the mitosis is present. Okay, the mitosis is present. Okay, just a minute, guys. Some people are not able to hear my audio. Okay, so we will see this cell. Okay, as they mature, the large central nucleus loses its nucleoli and becomes smaller and denser. And due to the high content of the RNA, as I told, there is an active protein synthesis occurring in the cytoplasm. It also renders the cytoplasm very deeply basophilic. Okay, deeply basophilic. So this is the diagram of the pro-normoblast. So this is the basophilic cytoplasm, large basophilic nucleus. Okay, and fine punctate chromatin. Okay, fine punctate chromatin, and you can see a small blue nucleoli. Okay, there is number of nucleoli present. Okay, which are blue in color. Okay, next stage is the early normoblast. Next is the early normoblast. So the size is 12 to 16 micrometers. Okay, the nucleus is very large but more condensed here. Okay, it is more condensed. Nucleoli has disappeared here, and there is presence of fine chromatin network, and the cytoplasm is still basophilic, and mitosis is still present. Okay, the cytoplasm is scanty here, deep blue and basophilic. The basophilic cytoplasm is due to the continuation of many polyribosomes in it, and therefore early normoblast is also called as basophilic erythroblast. Okay, nucleus is large, occupies 3/4 of the cell area. Nucleus is composed of dark violet heterochromatin clumps interspersed with the pink clumps of euchromatin. The chromatins are connected by linear strands, and this often gives nucleus the appearance of wheel spokes. Okay, so it undergoes rapid proliferation. So this is diagram. You can see the presence of heterochromatin here. Okay, the basophilic cytoplasm, large but condensed nucleus, no nucleoli, fine chromatin network. Okay, so it appears like a wheel spokes. Okay, you can see the presence of the heterochromatin, which is densely packed. Okay, and hemoglobin appears first time in all these three series. Okay, so as there is high content of RNA, the basic precursors for the hemoglobin are under process. So once this question was asked, so remember that the hemoglobin synthesis starts as early as early normoblast. In the recent DNB exam, this question was there. So the process to begin for the hemoglobin formation, it occurs as early as the early normoblast. Please make down this point. Okay, so early normoblast stage, there is hemoglobin synthesis has already begun. But if you see in the microscope, it is the intermediate normoblast stage where it appears on the microscope. So there is a difference in the question framed. Okay, so in the microscope, if you see, it is the polychromatic stage or the intermediate normoblast where it appears to be seen on the microscope, but it is the early normoblast stage where already the synthesis has begun. So this was the slight tricky question that was asked last time. Okay, so here the size of the intermediate normoblast is 10 to 14 micrometers. By now you might have observed the size of the cell is going on decreasing. Okay, nucleus now here it is coarse and deeply basophilic. Hemoglobin appears to be in the microscope here. In the microscope, in this stage, you can see the hemoglobin. Okay, and cytoplasm is polychromatic because of the presence of both basophilic RNA as well as acidophilic or eosinophilic hemoglobin. So this is called as polychromatic. Okay, polychromatic, and no nucleoli. Okay, the cell, the nucleus has no nucleoli. It is coarse and deeply basophilic. Still mitosis is present. Okay, still mitosis is present. So you can see this is the polychromatic. So different, both the colors are there. So it is not that prominent in this diagram, but if you see in the microscope, this is the polychromatic cytoplasm and coarse deeply basophilic nucleus. Next, coming to the late normoblast. Coming to the late normoblast, size again goes on decreasing, 8 to 12 micrometers. Nucleus again here it is small and pycnotic. Okay, it is pycnotic, means getting to disappear. Okay, pycnotic. So dark condensed nuclear chromatin in the last stage of which the nucleus. So this is the cell in the last stage. Okay, still the nucleus is present but becoming pycnotic. Okay, so cytoplasm is acidophilic because there is increasing the amount of hemoglobin. Okay, which is synthesized and released into cytoplasm, which with the diffuse basophilic hue. Okay, still you have got some basophilic hue due to the presence of the small amount of the RNA. Okay, Remember here in this stage the mitosis is absent. So this was another question that was asked. Okay, so in the late normoblast stage of the erythropoiesis, the mitosis is absent and only maturation is possible from this stage. So here from here there is no mitosis, but only the maturation phase begins. Okay, only the maturation is possible. Okay, so this is the diagram. So acidophilic cytoplasm with small basophilic hue and small pycnotic nucleus. Okay, and densely condensed chromatin. Okay, densely condensed chromatin. Next is the reticulocyte. So this is the premature cell of the erythroid series. Okay, premature cells of the erythroid series, that are the reticulocytes. So these are also called as juvenile cells. Okay, they are also called as juvenile red cells. Okay, devoid of nucleus. So there is no nucleus. So the last stage itself there was the nucleus becoming pycnotic, and in the reticulocyte there is complete absence of the nucleus. Okay, but still the nucleus has the cytoplasm has small ribosomal RNA. Okay, ribosomal RNA is there small, so that they can synthesize the hemoglobin. So they are acidophilic with a slight basophilic hue due to the fine reticulum of the RNA. This helps to distinguish from the mature RBCs. So what is the difference between the mature RBC and the reticulocyte on the microscope? It is the presence of the reticulum of the RNA. Okay, reticulum of the RNA. Okay, here the reticulocyte spends about 1 to 2 days in the bone marrow, then enters the circulation. So after spending 1 to 2 days in the bone marrow, the reticulocyte enters the circulation and remains there for another 1 to 2 days in the circulation, and finally becomes matured to the erythrocyte. Okay, matured to the erythrocyte. So this is the microscopic. So this can be given as a picture based question. So there is acidophilic cytoplasm with fine chromatin. Okay, cytoplasm is more acidophilic as with the slight basophilic hue, and you can see the fine reticulum of RNA. So this is the reticulocyte. Okay, now coming to something called as what is reticulocyte count. Okay, reticulocyte count. Okay, reticulocyte count. Okay, in normal range in the adults it is 0.5 to 2.5 percentage. Okay, percentage in the normal. Okay, but in infants it can range from 2 to 6%. The number falls during the first year of life to less than 1%, and then it attains the adult value. Okay, adult value. So the count increases in conditions where erythropoiesis is more. Okay, where erythropoiesis is more. So especially after hemorrhage. So whenever there is a hemorrhage, soon after hemorrhage, if you take the peripheral smear, you can see the count of the reticulocytes going higher because of the more increased erythropoietic activity. Okay, even during the treatment in case of anemias. Okay, if you are treating properly the cause, you can see the erythropoiesis is getting enhanced and the reticulocyte count increases. So that is another. Okay, then even in the high altitude. Okay, even in high altitude, you can expect the count to go high. Okay, so here coming to something called as what is reticulocyte response. What is reticulocyte response? The reticulocyte count is performed to assess the therapeutic response of the anemias, especially in which the patient is deficient of one of the substrate which is essential for the synthesis of red cells. When therapy begins, so whenever the therapy begins, the new red cells starts forming and get released. Okay, and so this results in the increase in the reticulocyte count. So this is called as reticulocyte response. The reticulocyte response indicates that a favorable response to the treatment. That means the treatment is correct. So, and this typically observed at the beginning of the treatment for the pernicious anemia or the iron deficiency anemia, and which you are going to treat accordingly. And this typically is observed in the beginning of the treatment. Okay, so suppose if there is a B12 deficiency, so if you correct it properly, then there is the erythropoiesis which is enhanced and there is increase in the reticulocyte count, and that is called as the reticulocyte response. Okay, and alteration in this reticulocyte count, we have two conditions, that is reticulocytosis and reticulocytopenia. Okay, reticulocytosis and reticulocytopenia. So what is so increase in the reticulocyte count, that is called as reticulocytosis. So these points are not written in this one, please note down. Okay, so there can be two causes for the reticulocytosis. Either it can be a physiological or a pathological one. Okay, physiologically what happens in newborns and infants, you have got higher count, that is physiological. Okay, even in high altitude, which is considered as physiological increase in the reticulocyte count, that is reticulocytosis. Coming to the pathological conditions, so we have got n number of conditions here, like the hemolytic anemia, acute hemorrhage, okay, during the treatment of deficiency anemias, okay, or any condition that stimulates the bone marrow to produce the red blood cells. So they're all pathological conditions, okay. And something called as reticulocytopenia. So there is no any physiological condition for the reticulocytopenia, okay. It always indicates a disease stage, okay. So it is seen mainly in the aplastic anemia. Remember this one, once it was asked, reticulocytopenia is seen in, okay. So it can be seen in aplastic anemia, myxedema, okay, myxedema, hypopituitarism, okay, hypopituitarism. Also it can be seen in leukoerythroblastic anemia, okay, leukoerythroblastic anemia. So these are the some of the few conditions where reticulocyte count is decreased, okay, mainly the aplastic anemia, myxedema, hypopituitarism, and leukoerythroblastic anemia, okay. So these are the some conditions where the reticulocyte count is decreased. And also you should know something called as reticulocyte index, okay. These things are not put on the slides purposefully, as to you have to take it down, okay. What is reticulocyte index? Effective erythropoiesis is estimated by reticulocyte count. So reticulocyte count is taken as a prognostic indicator, okay, prognostic indicator, which is normally expressed in percentage of the red blood cells, okay. So absolute reticulocytes is equal to reticulocyte percentage into red blood cell count. Remember, absolute reticulocytes is equal to reticulocyte percentage into RBC count, okay. So to use reticulocyte percent as a measure of the rate of red cell production, the percent may be corrected by a hematocrit value, okay. So this is called as corrected reticulocyte count, okay. Therefore reticulocyte index is equal to reticulocyte percentage into actual hematocrit divided by normal hematocrit. So take down this formula, okay. I have not written here purposefully so that you should take it down. So the reticulocyte index is equal to, I repeat again, reticulocyte percentage into actual hematocrit divided by normal hematocrit, okay. This will give you the corrected reticulocyte count. Remember, this reticulocyte count is used as a prognostic indicator to know the prognosis of the disease, whether we are treating correctly or not. Are you following, guys?
Yes, sir.
Okay, fine.
So what is the clinical significance of the reticulocyte index?
Index. So sometimes what happens, the hematocrit value can be altered, okay. Suppose if the hematocrit value actual, what you are finding, that is important, and you should take it with respect to the normal hematocrit value, okay. Sometimes if there is a hemorrhage, okay, bone marrow may be normal, your absolutely no person is absolutely normal, but there is loss of red blood cells, isn't it?
Yes, sir.
So in such cases we require this correction, okay, because the person, if the person is actually diseased inside the body, some other causes, so there comes some variations. Therefore we use this hematocrit value also is taken into count, okay. RBC count. Hematocrit is nothing but you are indirectly going to measure the RBC count, isn't it?
Yes, sir.
So that is also important. So actual hematocrit divided by normal hematocrit multiplied by reticulocyte percentage will give you the corrected reticulocyte count. That is very important, okay. Have you followed?
Yes, sir.
Yeah. Next, coming to the last stage, that is the erythrocyte, okay, RBC, okay. This is the mature red blood cell, okay, biconcave shape, okay, disc shaped, size 7.2 micrometers, okay, 7.2 micrometers. So now we could have, I think you might have observed in all these stages, that is what happened. The first, the cell size progressively decreased, and size of the nucleus and number of nucleoli decreased. Chromatin material condensed, okay, and finally the nucleus disappeared, okay. And staining reaction you saw from basophilic to polychromatic, and then finally to the acidophilic, okay, cytoplasm, okay. So here there is no nucleus, there is no nucleus. Cytoplasm is acidophilic with central pallor because of the biconcavity. There is a central pallor, okay. You can see this is the central pallor. So this is deeply acidophilic cytoplasm, and this is central pallor, okay. So now you see all these stages. So the cell size went on decreasing, as I told, all the features. Okay, the nucleus size of the nucleus also went on decreasing. Number of nuclei also decreased. Chromatin material condensed, and finally the nucleus disappeared, and the shape also changed to the biconcave shape, to the physiological adaptations. Okay, so this is same flow chart. Okay, again it's a repeat. So now coming to the time required for erythropoiesis. Okay, so the burst forming unit erythropoiesis proliferates and matures into colony forming unit erythrocyte in 6 to 8 days. Remember, from burst forming to the colony forming it is 6 to 8 days. From pronormoblast to erythrocyte 5 to 7 days. So these are asked repeatedly, the numbers. Okay, so you have to keep it in mind. Okay, and so total time is approximately 2 weeks. So for erythropoiesis, finally, okay, from the stem cells to the mature erythrocyte, it requires 2 weeks of time. So whenever you are treating anemias, you require minimum this time, 2 weeks, to do a peripheral smear and count the reticulocytes or anything, whatever you want to do. So minimum time that you should give for the lab investigation to confirm whether the the number of the RBCs are increasing or not. So 2 weeks is the total time. Okay. Next, coming to the regulation of erythropoiesis. Coming to the regulation of, so total number of RBCs in circulation is regulated by such a way that there is adequate number of red blood cells always available to provide the sufficient tissue oxygenation, but does not exceed the limit. Suppose if it exceeds the limit, what happens? It will impede the blood flow by increasing the viscosity of the blood. So that is kept in mind. Okay, that's how it is regulated. So it is done by a feedback control mechanism. Okay, feedback control mechanism. So what are the factors? Main is the tissue hypoxia, which is the triggering factor for erythropoiesis. Hypoxia. Okay, tissue hypoxia. Mainly the renal hypoxia, that is very important, that we will discuss in the coming slides. Next is erythropoietin, which is the main hormone for the erythropoiesis. Okay. Next, growth factors are required. Maturation factors are required. Various small minerals, vitamins, and proteins also very much important for the regulation of your erythropoiesis. So coming one by one. So first is the tissue hypoxia. So hypoxia, that is deficient tissue oxygenation, is a basic triggering factor for erythropoiesis. This is the basic regulator, hypoxia. Okay. So the tissue hypoxia due to any cause, okay, that will compensate by increasing the production of hormone called as erythropoietin. So what is erythropoietin? So coming to the erythropoietin is a hormone, okay, which was discovered in 1906 by a French professor called as Dr. Paul Cornot, and his associates suggested that hypoxia generates a humoral factor that is capable of stimulating the red cell blood cell production. So then what is the source for this erythropoietin? Okay, it's a glycoprotein. Source is mainly 85% is the kidney. Okay, remember, once this was asked, simple question, but you need to remember the numbers and this side. Okay, 85% is the kidney, 15% is the liver. Okay, and other sites also possible as brain, uterus, and oviducts. Remember, so even these are the sites for the erythropoietin. Okay, then coming to the receptor. Okay, it's a, as I told, it's a glycoprotein having 165 amino acids. Okay, there are 4 oligosaccharide chains attached with the polypeptide chain. These oligosaccharide chains are necessary for the physiological activity of the erythropoietin, and the molecular weight of erythropoietin is, remember, 34,000 Daltons. Okay, and coming to the mechanism of action, that is the receptor. It is the linear protein with single transmembrane domain. Okay, and the erythropoietin mainly acts on the erythropoietin receptors that belong to the cytokine receptor superfamily. Okay, cytokine receptor superfamily. This receptor has got tyrosine kinase activity. These have got the tyrosine kinase activity. Binding of erythropoietin with the receptor initiates the activation of the cascade of serine and threonine kinase that will finally lead to the activation of JAK2 protein. And formation of this JAK2 protein and other signal proteins brings about the changes in the cell functions in a similar way to that of the growth hormone. Okay, like the growth hormone, the same activity goes on. Okay. So what are the actions? It stimulates the colony forming unit erythrocytes to proliferate and differentiate into pronormoblast. Okay, causes precursors to pass more rapidly through the different stages of the erythropoiesis, mainly the reticulocytes. Okay, it mainly acts on the progenitor cells and the early precursor cells, especially stimulating the CFU and the BFU. Okay, mainly. Okay, and it decreases the cell cycle length of the precursor cell so that there is enhanced mitosis and more faster erythropoiesis can occur. Okay, also it facilitates the maturation of the normoblast. Okay, and high doses also stimulates the burst forming unit erythrocyte series. Okay, it increases the hemoglobin synthesis as well. Remember, it also increases the synthesis of the hemoglobin. It acts on the stem cells to promote their transformation towards the erythroid series, and also stimulates the early release of the immature erythrocytes into the circulation. Okay, into the circulation. So these are the various functions of the actions of the erythropoietin. Okay, erythropoietin. Okay, so metabolism, it is inactivated in the liver and excreted in the urine, and it is regulated mainly by the hypoxia, renal hypoxia, which will stimulate the synthesis and release of the, because 85% of the erythropoietin is released by the kidney. Okay, conditions, okay, mainly the renal hypoxia and some other non-renal factors also can induce, and pro-erythroblast itself can regulate the erythropoietin levels, makes the cells that pass the rapid series. Okay, so makes the erythropoietin makes to go more rapidly through the different phases of the erythropoiesis. Okay, also this erythropoietin, remember, so these are the other questions which are frequently asked. So erythropoietin levels are increased by androgens, male hormones. Okay, so in males you can expect the more number of RBCs when compared to the females. Also TSH and thyroid hormone also have got effect on the erythropoiesis, so that is erythropoietin release. So in case of hypothyroidism, you can expect anemia. So because this hormone also regulates the erythropoietin. Okay, and cortisol, ACTH, growth hormone, etc. are increasing the secretion and release of the erythropoietin. Okay, even catecholamines, which will cause hypoxia, will trigger the release of erythropoietin. Also some nucleotides like cyclic KMP, NAD, NADP, these also will enhance the production of the erythropoietin. So decreased. So the erythropoietin is decreased in chronic kidney diseases, mainly which will cause the anemia of chronic kidney disease. Okay, this is the major. Also, estrogens will inhibit the erythropoiesis by inhibiting the erythropoietin production. Remember, I have not written here estrogen. This is another hormone which will inhibit the erythropoiesis by inhibiting the erythropoietin production, also by decreasing the response to the stem cells by erythropoietin. So estrogen also decreases the hepatic synthesis of the globin. Okay, globulin. Remember, this I have not written here. Estrogen is hormone, whereas androgen increases the erythropoietin, whereas estrogen decreases by inhibiting it. Okay, so these are the factors which will increase and decrease. Okay, so remember these conditions and hormones. Okay, so this is the overall balance feedback control. Okay, whenever there is reduced oxygen level in the kidney, it is stimulated, erythropoietin is released, it goes and acts on the bone marrow, then bone marrow there is enhanced erythropoiesis, and more reticulocytes and the matured RBCs are released into the circulation. Okay, so that is the balance. Next regulating factor are the growth factors. Next are the growth factors. Okay, so interleukin 1, 3, interleukin 6. So these are the main factors that are responsible for the erythropoiesis in the early stages of the precursors. Okay, and growth, that is granulocyte, monocyte, colony stimulating factors, CSF, also very important for the regulation. Next we come to the maturation factors. As you people know that vitamin B12 is required, folic acid is required for the final maturation of the cells, especially the RBCs. Okay, these are the maturation factors. Okay, so in detail you will be studying these, how folate trap, all other things. Okay, that is folate trap is there. Okay, methyl tetrahydrofolate trap, all those things we'll be seeing in biochemistry. Just to remember here, these are the maturation factors important for the DNA synthesis in the RBCs. Okay, so lack of maturation factors. Hello,
sir, iron is not required for maturation of RBC.
Maturation is not required. It is only for hemoglobin synthesis.
Yes, sir.
Not for the maturation. Maturation is mainly by vitamin B12 and folic acid. Remember, okay?
Okay, sir.
Iron is for hemoglobin. That hemoglobin topic will be taken again. Don't worry. Huh? So lack of these maturation factors, especially the B12, okay, there is decreased DNA production and prolongs the time for cell division, and there will be finally the failure of nuclear maturation. Okay, so in such cases, what happens? You can expect erythroblastic cells in the bone marrow, which will produce larger erythrocytes. Normally, the biconcave shape is not there. Okay, they are called as macroovalocytes. Okay, and this membrane also is not stabilized. They are malformed, so they are more fragile. Okay, increased fragility in this. Okay, if there is a vitamin B12 deficiency. Okay, so not able to meet the O2 demand. Finally, what happens? Since the RBCs are more fragile, the tissues will not be able to meet the O2 demand. So these are the macroovalocytes. Okay, macro, because of the deficiency of the maturation factors. Okay, so also you require other vitamins like vitamin C, because the absorption of the iron from the GIT is mainly as the ferrous, but it helps, vitamin C helps in converting ferric to ferrous form. Okay, so this is how vitamin C is also very important. Also you require vitamin 6, vitamin B5. Okay, also required for the normal erythropoiesis. Also require proteins and iron. So iron are not included because I'm taking that into the hemoglobin synthesis in that part. Okay, proteins also required because hemoglobin, okay, globin synthesis is very important, so proteins are required. So minerals like, okay, and trace elements like iron, so iron came here, that is required for the heme synthesis. Okay, hemoglobin. So copper is required, cobalt, nickel, manganese, zinc. So all these micronutrients you need to supplement when you are treating a iron deficiency anemia or any anemias. Okay, because these are all the integral. So you might have seen doctors prescribing protein powder and other multivitamins because they indirectly help. Just giving iron is not enough, so you need to supplement multivitamins as well as the proteins, then only there will be effective response you can expect. Okay, are you following the class, guys?
Yes, sir.
Yeah, fine. So these are the various factors. Okay, next, another important factor, that is the intrinsic factor. As you know, from the gastric mucosa, oxyntic cells, okay, which will release, okay, intrinsic factor. Okay, so that is very important for the absorption of vitamin B12. Okay, all interlinked. In atrophic gastritis or gastrectomy, you can expect anemia because of the lack of intrinsic factor of Castle. Okay, intrinsic factor of Castle. Okay, so this is how all this is regulated by various factors. Okay, this completes the erythropoiesis. Guys, you have any questions? You can ask. So we'll go to the next small topic, the WBCs. Coming to the white blood cells, okay, white blood corpuscles, they are the mobile units of the body's protective system. They are the soldiers defending against the microorganisms. Okay, seek out and destroy the foreign invaders by the phagocytosis and by forming the antibodies and sensitized lymphocytes. They differ from RBCs formed in the bone marrow and lymphoid organs. Their average lifespan is very short, whereas RBCs it was 120 days. Okay, so RBCs, the properties will be taken along with the hemoglobin. Okay, now today just the erythropoiesis, because many questions are asked from the erythropoiesis and their factors. Okay, so the average lifespan of the WBCs is very short. Therefore, in the circulation you see less number of when you see the myeloid erythroid ratio, that is less in circulation. Okay, so the myeloid erythroid ratio is 75 and 25 in marrow, and in circulation it is opposite. Okay, coming to the classification. Okay, WBCs are mainly classified into granulocytes and agranulocytes. Okay, granulocytes, you know, neutrophil, eosinophil, and basophil because of the granules present in them, and agranulocytes mainly the monocytes and the lymphocytes. Coming to the normal values, in adults the count varies from 4,000 to 11,000 cells per cubic millimeters. At birth it is physiologically increased 10,000 to 25,000 cells per cubic mm. Okay, and these are the differential counts. So once this question was asked, what is the differential count? So this is from the your Ganom. Okay, so these are standard values we have to always rely. Okay, the neutrophil differential count is 50 to 70%, eosinophil 1 to 4%, basophil 0.4%, or they can take range 0 to 1% as well. Okay, in Ganom it is given 0.4%. Okay, monocyte 2 to 8%, lymphocytes 20 to 40%. So if you take the absolute value, the neutrophil range from 2,000 to 7,000 cells, eosinophil 50 to 500 cells, basophil 10 to 100 cells per cubic mm, monocytes 200 to 800, lymphocytes 1,500 to 4,000 cells per cubic millimeters. Okay, so this is the differential count. So this can be asked, so you should remember this range exactly. Okay, coming to the neutrophil, as you see, you can see in the diagram, the size is 10 to 14 micrometers. Okay, differential count, as I told, 50 to 70%. In children it is more. So it is a macrophage, actively phagocytic. Okay, it remains for 7 hours in the blood and 4 to 5 days in the tissues. Okay, it is, you can see the counting of the numbers of the neutrophils with different nuclear lobes. It is a multi-lobed. Okay, expressing the count as, so something you should know about the Arnett count here. Cook's Arnath count. So once this question was asked recently, okay, Arnath count is useful in judging the rate of formation of the neutrophils. Okay, the three-lobed cells are fully mature and functionally most efficient. So this was the question asked. Okay, three-lobe means it comes under stage 3. Okay, three lobes comes under stage 3. So the Arnath, who was the person who did this study, okay, in the peripheral smear. Stage 1 means there is one nuclear lobe. Stage 2 means 2 lobes. Okay, stage 3 means 3 lobes connected by chromatin. Stage 4 means 4 lobes. 5 means it is containing only 5. Okay, like that. So what is the percentage present? Okay, usually the stage 3 with the 3 lobes, okay, they're highly efficient. Okay, they are fully mature and functionally most efficient. So they constitute 40 to 50% in the peripheral smear. Okay, the presence of younger cells shift to the left. Okay, more mature cells. Okay, remember, younger cells means shift to the left, more mature means shift to the right. Okay, in this staging. Okay, so that provides an important information about the rate of formation on release of the neutrophils from the bone marrow. Just remember there is something called as Arnath count. Stage 3, where the highest percentage, that is 40 to 50, they are fully mature and functionally most efficient. So this is how the Arnath count is done. Okay, as I told, neutrophils, they are multi-lobed nucleus. They contain fine purple granules. Remember, sometimes these words can be asked as a single liner for you. Okay, the granules present in the neutrophils are fine granules. Remember, fine granules, they are purple. Okay, fine purple granules present. Okay, they contain mainly the primary granules and the secondary. So sometimes this also can be asked, one liner. The primary granules present in neutrophils are mainly the lysozyme and the peroxidase enzymes. Okay, and secondary granules are mainly the lactoferrin, that is the iron binding protein, and you have got cationic bactericidal protein, very important for the killing of the bacteria. Cationic bactericidal protein is a part of secondary granules, and vitamin B12 binding protein and gelatinase, and main function is phagocytosis. So, and WBCs, okay, like your RBCs, it also has got, okay, leukopoiesis. Okay, same steps like the pluripotent stem cell, then myeloid series, then they get committed to the granulocyte monocyte progenitor, then finally you have got either the neutrophil, basophil, eosinophil, or the monocyte. So that is not that much important for you from the point of examination point of view, but follows the same like the your erythropoiesis. It has got all the series of the cells. Okay, it has got all the series of the cells there. Okay, coming to the eosinophil, okay, size is 10 to 14, same size. Okay, or neutrophil, basophil, all the same, 10 to 14 micrometers. Differential count is 2 to 4%. Remember, it is bilobed, spectacle shape. Okay, bilobed. Okay, lifespan is 8 to 12 days. Here you remember it is the coarse granules which are present in the cytoplasm. In neutrophil it was fine granules. In eosine it is coarse granules. You can see the coarse granules here. See, these are the coarse granules. What are the contents? See, these are the major basic protein which are present in the coarse granules. Eosinophilic cationic protein, histaminase enzyme, aryl sulfatase enzyme, eosinophil peroxidase enzyme, and lysophospholipase enzyme. So these are the various enzymes present in the coarse granules of the eosinophil. Okay, and what are the functions? It defends the body from allergic reactions mainly. Okay, neutralizes the allergen. It is also larvicidal, also parasite. Okay, it also can kill the parasites. Okay, parasiticidal. Okay, and it's also weakly phagocytic. Also has weak phagocytic activity. Also limits the effects of antigen antibody reactions. Okay, by this it will engulf the complexes. Okay, that will phagocytose the antigen antibody complexes as well. Okay, coming to the basophil, you can see it is a S-shaped nucleus. Okay, differential count 0.4 or 0 to 1%, same size 10 to 14 micrometers, similar to the mast cells. It is multi-lobed, it looks like S-shaped. Okay, and the thing is it has got deep blue coarse granules which will override the nucleus. So you can see the deep blue, okay, very coarse granules which are overlying the nucleus. Okay, very difficult to find in the peripheral smear until unless there is a disease. Okay, or you have got a electronic microscope like that. So a normal microscope, it is very difficult to find out. Okay, and the granules are very obscure in the nucleus. Okay, which will cover the nucleus and cytoplasm. These granules mainly contain heparin. Remember, there can be a tricky question based on the granules which are present here. Okay, contents. from the eosinophil and the basophil. So in the basophils, it is mainly the heparin, histamine, and slow reacting substance. Okay, slow reacting substance. So mainly it is phagocytic. Heparin, which is present in basophil, prevents the intravascular clotting. Okay, very important. And histamine and slow reacting substance, they take part in the IgE mediated allergic reactions along with the mast cells. Okay, along with the mast cells, they take part in the that is IgE mediated allergic reactions. Coming to the monocytes. Okay, you can see this is the largest cell, 10 to 18 micrometers. Differential count is 2 to 8%. It has got a large pale cells. Okay, pale staining or indented eccentric nucleus. Okay, you can see it is a kidney shaped nucleus. So normally what the word we use is it is the kidney shape. Okay, and remains in circulation for 10 to 20 hours, and it has got the cytoplasm. It is very clear. It has got a fine azure granules. Okay, fine azure granules, and it goes to the tissues. There it swells up. Okay, become a tissue macrophage because it is a part of your. I'll come to that point. Okay, it becomes a tissue macrophage, survives for at least 3 months there, and it continues the defense activity and ends as a multinucleated giant cell. Okay, continues as a ends as the multinucleated giant cell. Okay, what are the functions? As I told, mainly phagocytosis. Okay, it is a part of your mononuclear macrophage system, which can engulf a bacteria it can engulf as many as 100 bacteria. Also participates in the immune responses as well. They process the antigen and present it to the T or B lymphocytes. Also, monocytes stimulates the secretion of interleukin 1 and also promotes the proliferation and maturation of the T lymphocytes. Also destroys the senescent old RBCs and initiates the catabolism of hemoglobin. So monocyte has got various activities, as you can see here. Okay, coming to the lymphocytes, you have got small lymphocytes and large lymphocytes. Okay, the small lymphocytes 80%. Okay, percentage in circulation 7 to 10 micrometers. Okay, and large it is 10 to 14 micrometers, same as that of your neutrophil size. It is 20%. Okay, so the differential count is 20 to 40% lymphocytes. Okay, they are round, non-granular. There is no granules. They are called agranulocytes. Large, round, centrally placed nucleus. Okay, formed in the bone marrow, also in the lymphoid organs. Okay, that is the thymus. 80% is produced in the thymus and 20% in the busa equivalent of the bone marrow. Okay, busa equivalents 20%. 80% is mainly in the thymus. Okay, and lymphocytes, as you know, it from the site of formation gets into the circulation and finally to the tissues. The lifespan is weeks to months. Functions mainly your immunity. So immunity I will take in a different class in detail. You will see how the cellular immunity is there, what is the mechanism actually occurring in the cellular immunity, and how humoral immunity by producing the antibodies. So that we will see in detail. Okay. Now now a defensive function of the. So I'm coming to the neutrophils. Back to the neutrophil. Okay, neutrophil attacks and destroys the bacteria, virus, or any other injurious agents. Can destroy even in the circulations. Monocytes, as I told, can kill in circulation as many as 100 bacteria can be engulfed, become a macrophage that is 80 micrometers in size in tissue, because tissue macrophage, and actively phagocytic. Okay, phagocytosis, that is cellular ingestion of the offending agent, that is the phagocytosis. Okay, so based on the selection, if there is a rough surface, if there is no any protective coat, antibodies, complement. So if there is anything present in our body like this, so this phagocytosis mechanism becomes active. If there is a rough surface, if there is no any protective protein coating, if there is antibodies complements there, immediately to the bacterial membrane they get phagocytosed by our defense lines, that is the neutrophils and the monocytes. What are the steps involved in the defense mechanism? That is margination, diapedesis, chemotaxis, opsonization, phagocytosis. So sometimes this can be asked in a sequence, which is the correct sequence. First is margination, next is diapedesis, next is chemotaxis, next opsonization, and finally the phagocytosis. In phagocytosis, first there is a phagosome formation, then there is degranulation, that is the granules get released, then there is the respiratory burst. Okay, production of the respiratory burst mechanism is there, that we'll see in detail, and there is discharge of the enzymes which are involved in the killing of the bacteria, that is myeloperoxidase, and digestion of the intracellular enzyme, and lastly the walling of effect. Okay, you can see here, this is the various, so the cells, okay, or neutrophil is in the circulation. Whenever there is a indication, they come closer to the endothelial surface, goes towards the site of bacteria or the chemoattractants, okay, fermenting diapedesis, and finally the chemotaxis, the chemicals which are released by the injurious tissues or the bacteria, they act as tasty products. Then there is chemotaxis here. Okay, again we will see one by one. So margination, first step was the margination. So neutrophils are attracted by towards the endothelial surface by selectins, bind to the neutrophil adhesion molecules of integrin family. Okay, then there is diapedesis. That diapedesis means squeezing through the small pores in the endothelium, which will involve mainly the microtubules and the microfilaments. And there is a amoeboid motion. Okay, like amoeba, there is a amoeboid motion. The velocity can be 40 micrometers per minute. Then there is opsonization. Okay, because the complements and the antibodies which are attached to the bacteria, they render them very tasty. Okay, that is opsonization. Okay, then finally the chemotaxis, the chemoattractants, which are mainly the bacterial toxins, degenerative products of the inflamed tissues, reaction products of the activated complement system as well, and reaction products caused by the plasma clotting. So all these can act as chemoattractant, and they will attract these neutrophils there. Okay, this chemotactic substance attracts the neutrophil or the monocyte, okay, in the infected area, and depending upon the concentration gradient, they will move to the source. So more is the concentration gradient, means there is more the inflamed area, more number of neutrophils and monocytes gets recruited towards that area. Okay, like that. Then finally there is phagocytosis, which is properly occurring there. Okay, neutrophils, now they become the macrophages. Monocytes we call it as macrophages because of the size difference. Okay, so project the pseudopodia. Those are, there is a change in the cell membrane, they become pseudopodia, means they extend and they enclose the bacteria, invaginate inside, and it breaks from the cell membrane and fuses with the cell membrane of the neutrophil or the monocyte, become phagosome. Okay, and there is exocytosis of the granules now get released, and there is digestion of the intracellular enzyme. So these are the various sequence how it is occurring. Okay, so you can see here, this is the pseudopodia. You can like the amoeboid motion. Okay, pseudopodia. So you can see here the bacteria coming. Okay, gets finally getting into pieces. Okay, so phagocytosis, you can see the bacteria which is getting the pseudopodia. You can see there is formation of the phagosome. This phagosome is taken inside, the granules which are released will kill it, and the products are released. Okay, this is how the phagocytosis occurs. Guys, are you following? Are you following, guys?
Yes, sir.
Yeah, fine. Okay, so various opsonins, okay, they come and attach, then they get engulfed, formation of the phagosome. Okay, then there is a intracellular killing. Okay, so this is another diagram depicting the phagocytosis. Okay, this is how it occurs. Okay, they come and get attached to the opsonin receptors, then formation of the, there is invagination of the cell membrane, formation of the phagosome, and there is intracellular killing. Intracellular killing. So inflammation, so this will be dealt in detail in our pathology. Okay, inflammation, there is a vasodilation, there is increased capillary permeability, clotting of the fluid in the interstitium occurs, migration of your granulocytes and monocytes, that is neutrophils, occur, then swelling of the tissue occurs. So that's all inflammation. So defense mechanism, so tissue macrophages within minutes, neutrophils within hours. Okay, they come, and monocytes from the blood from hours. Okay, within hours to days also it can activate and defense your body. Okay, participate in the defense mechanism. Okay, and granulocytes and monocytes, they can from days to weeks it can occur. Okay, what are the differences? So neutrophils can phagocytose 5 to 20 bacteria, begins phagocytosis immediately. They are less powerful, they mainly take more particles than bacteria, shorter lifespan, and die in the process. Whereas macrophages, even they can engulf as many as 100 bacteria, little ability to kill them in the circulation, but they are more powerful, can engulf even RBCs, can extrude the residual products and can live for many more months. Okay, activated by the immune system as well, but they do not die as such. Okay, so they completely do the process and then only they get senated. Okay, so these are the differences between the slight differences in the neutrophils and macrophages. So they just so nothing can be asked as such, I think, in the entrance exam, but just remember that these monocytes macrophage system that engulf more number of bacteria. Okay, even it's more powerful system. Okay, now coming to the reticuloendothelial system. Okay, monocyte macrophage system, that is MMS, mononuclear phagocytic system, MPS. Okay, generalized phagocytic system, this is reticuloendothelial system. Special group of cells are there, powerful phagocytes. Okay, mainly phagocytosis is the main process here, and they can be stained by supravital stains. Monocytes, they are mainly the macrophages. In the liver, they are called as Kupffer cells. In the CNS, they are called as microglia. In the lungs, they are called as alveolar macrophages. So this can be a one-word question sometimes. That is these are the part of your reticuloendothelial system. In the skin, they are called as Langerhans cells. In the bone, they are called as osteoclast cells. In the lymph nodes, spleen, and bone marrow, they are called as dendritic cells. In the connective tissue, they are called as histiocytes. So in the various organ system, so there are the cells are named differently, but the function is same. That is the phagocytosis. Okay, microglia in the CNS, alveolar macrophages in the lungs, Langerhans cells in the skin. In the bone, they are called as osteoclasts. In dendritic cells in the lymph nodes, spleen, or the bone marrow. In the connective tissue, they are called as histiocytes. What are the functions? As I told, mainly the phagocytic action. Okay, main power, they are very powerful phagocytic action. They engulf larger particles as well. Engulf more number of bacteria, even as high as 100. Survive even after the ingestion of the bacteria. They do not die immediately. Okay, they ingest, destroy the RBCs and release even the bilirubin. Okay, also they can destroy the dead WB, already dead other WBs, and even the platelets they can destroy by engulfing them. Okay, they ingest and process the antigen. Okay, and it can present it to the lymphocyte. Okay, they play a role in the immunity. They also produce interleukin-1, which will activate your T lymphocytes. Also, it will produce colony stimulating factor GM, which will regulate the erythropoiesis as well. Also, it initiates the development of even antibodies, and they're activated by lymphokines of T lymphocytes, and they can migrate to the area of inflammation and engulf the bacteria. Okay, and the site of hemopoiesis during the even fetal life. Okay, they are the site of the hemopoiesis. So reticuloendothelial cells also, they are the site of hemopoiesis during the even the fetal life. Okay, these are the various functions. So various functions of your reticuloendothelial system. Okay, guys, did you have understood this? So there were numerous activities. Okay, so this will complete the brief introduction to the your WBCs. In the next class, we will see in detail about the immunity. Okay, even some points regarding the RBCs as well, and we will see regarding the hemoglobin and some points regarding the platelets, and we will finally see some points regarding the blood transfusion. Okay, hope you have followed the class. Okay, we will see you in the next class. Any doubts, guys?
No, sir.
Okay, fine. Then we will conclude. Okay, thank you. Hello. Class is over. Yeah. Yeah. Shall I exit? Yeah.
Thank you all.